Hey there, welcome back to the training. We are going to talk about recognizing complex trauma in the context of intergenerational trauma. So, this is a really important module, and this lesson is really important for the foundational knowledge of complex trauma and how that impacts therapy and the parent-child relationship and everything in the treatment of intergenerational trauma. So, we'll be talking about understanding self identity and a sense of self, emotional and behavioral patterns in relationships, including the therapy relationship, and psychological and emotional fragmentation and trauma bonds as well. Now, this is a very complex subject. We could do a whole long course on just complex trauma. So, this is just kind of skimming the surface and giving you what you need to have that foundational knowledge of complex trauma in the context of intergenerational trauma. So, this is critical to understand due to the unresolved trauma of the caregiver that mediates that transmission of intergenerational trauma between generations. So that's where it's very important to understand this and be aware of how it impacts therapy. It's complex because it's multifaceted and layered. There's a lot of variety within the umbrella of complex trauma. So this is an overview to support identification of some of the characteristics and recognition of the impacts. So that variation within complex trauma, if you look at it like a spectrum from PTSD symptoms to your more severe dissociative disorders where you've got DID, that's kind of the range of what we're talking about. So not all people with complex trauma end up with a DID diagnosis. So there is a spectrum, and we need to know where on the spectrum, what are the things that the caregiver is dealing with that may impact therapy, that definitely impact the parent-child relationship, and that we need to support them with. So we're going to start with understanding self-identity and a sense of self. So I come from an interpersonal neurobiology perspective where we look at domains of integration. And this is Daniel Siegel's work, and it's really helpful for understanding dissociation. So there are several domains of integration, and I'm going to briefly kind of cover these. Again, I would have to go into a lot of hours of training to really communicate the depth of these, the integration of these domains. The first is consciousness. So that is just awareness of things that are happening. You have awareness of what's happening in your body, awareness of you're in touch in the present moment. Next is bilateral, so that's left and right hemisphere. Vertical is top down and bottom up, so that's having connection between those two where there's integration and there's communication between them. And we'll get more into what integration is in a minute. There's memory integration, so this means that people remember things and they're stored in their memory, and they're not just fragments of memories that kind of pop in that were kind of dissociated or they're not aware of. There's narrative integration. So that's how the story of life or the understanding of relationships or experiences, they have it like a story that makes sense, and it's not just choppy fragments all over the place. State integration is your parts work. So that is having different states that are linked together. So they're aware of each other, or there's kind of some connection between them, but they're also differentiated, which we'll get into in a minute. Interpersonal integration is the integration of relationships in life and creating a cohesive whole, including those relationships. Temporal integration is having a sense of time and having a sense of the past, present, and future. And transpersonal integration is kind of your more spiritual, cultural, all those things that give meaning to life and having those integrated into our experience. So integration is basically based on these various domains having linkages with differentiation. So linkages means that there is awareness, the person has awareness, or there's information that's connected, and it helps provide better information for making decisions, things like that. And differentiation means that they're also some of these domains are highly specialized. All of them are highly specialized, but they have pockets where they're very different from all the other domains of integration. So parts are a really good example. They're highly specialized. You may have a part that's like a firefighter, um, and it's highly specialized for alarm, for reacting, but you also want it connected into other parts of the person. And when we don't have that linkage with differentiation, that's when we see things in therapy and mental health symptoms. So I kind of look at it as being a generalist with specializations. The generalist part is those are the linkages where you want these pieces to be able to fit together. So if you're a generalist, you want to be able to have skills to work with anxiety, depression, trauma, maybe relational issues, maybe parent-child work. But they're linked together, and your interventions can kind of support all of those difficulties. Differentiation would be your specializations for treating intergenerational trauma or treating compulsive gambling or treating couples. So that's the generalist with specializations. That's how I kind of look at integration when we look at linkages with differentiation. So when there's a lack of integration in any of those domains, there becomes kind of this compartmentalization or walling off of states, experiences, memories, the sense of time. And this can cause huge impacts for a person when you have these kind of capsules or these things that are walled off and not integrated into the rest of the domains in the experience. So clients that have difficulties with integration usually have a distorted or unstable sense of self and time, and the challenges in therapy can be pretty significant. So, because of this lack of integration, there's a huge impact on the person's sense of self or their identity. So, they can experience a lot of identity confusion. They may shift themselves to meet others' expectations. So they'll act in one way with one person, but in a totally different way with another. And they're they can't define clearly who they are across relationships. And sometimes if they get in a situation where the relationship isn't working or there's some dissatisfaction, they can really grow to resent that situation because they feel like they gave up a part of themselves to meet the needs and to make this relationship okay. And it wasn't. So all that effort, they can become very frustrated and angry and have resentments later if it doesn't work the way that they needed it to. And they may not be able to stay consistent across like relationships or across situations because they're constantly shifting. So it makes it difficult if those situations or people come together in time and space. They may also have what Janina Fisher refers to as a false self, where they mask their deeper identity and they really don't let people in to know kind of who they are and what they're about. So they present this persona. It's like wearing a mask, but that's kind of the false self. And one of the main things that can be problematic, especially with trauma and intergenerational trauma and parent-child relationships, is a lack of internal safety. And this information comes from both Janina Fisher and Dan Siegel. This is where they can't speak up. They may not know their own needs. They can't assert their needs or assert who they are or what they are experiencing. And there's always an internal state of danger or life threat. So they're not even safe within their own skin. They don't trust their responses. They don't trust their body. They don't trust their senses, their own internal wisdom. They're always in an internal state of danger and life threat. So there can be a lot of indecision and self-sabotage that you see along with this. So how do we deal with this in therapy? Again, we could go on and on about this, but just for a brief overview, we're going to go into structural dissociation later in more depth. But in brief, structural dissociation identifies parts and their integration or lack of integration. So it's kind of a scale or stages of how integrated these parts are. And parts are normal and healthy. We all have them. They just become problematic when they're not integrated, when they're not linked, and when they don't have that differentiation. So if they're not integrated into the whole sense of self of the individual, that's where they become problematic, because they take on, they're split off, or they're too strong and they're not connecting with the individual themselves. So they talk in structural dissociation, and this again is from Janina Fisher. She talks about a life as usual part. So this is kind of what you see on the outside, what you'll see at work, what people will see at school. It's just kind of going on life as usual. And then they look at like your animal drives and defenses, and that's how they look at parts and trauma-related parts as well. So these drives and defenses are fight, flight, freeze, submit or collapse, and attachment. So that's how they kind of categorize those parts. And I know IFS, internal family systems, has a much more broad interpretation of these parts, and there's more facets to the parts, but for structural dissociation, that's how we look at it. When these drives and defenses are not linked and are differentiated, they're too differentiated because there's no linkages, they can have a lack of or really poor memory, because between these parts, there's no communication and no integration of that information. So they won't remember things, or they can end up in a situation where they went somewhere and they don't remember driving there. So these parts can create internal conflict and a huge lack of safety. That's where that internal sense of safety is problematic, because of the conflict between these parts. So an example of this would be if you have very differentiated but not linked parts of fight or flight, and very differentiated and not linked parts for attach, you're going to get that back and forth of needing and wanting relationship, but fighting or flighting out of it. And that is the root of disorganized attachment, is this difficulty between these parts. So they desperately need attachment, but that fight or flight part creates that push and pull between pursuing a relationship and fighting against it. So they can feel threatened by the very relationship that they need and have to have for survival. This is the main conflict when we're working with disorganized attachment. I also believe that this dynamic, that push-pull, can be the root of the transmission of intergenerational trauma between parent and child too, because there's this need to attach, need to make things different. There's that drive, but it's also it's also impacted by fight, flight, freeze, submit, and collapse. So it's critical to identify complex trauma in parents and the impacts of developmental trauma in children, especially when it comes to attachment behaviors. Now we're going to look at emotional and behavioral patterns in relationships and how trauma affects emotion regulation and expression. So there can be difficulties with affect recognition. So they don't have awareness of emotional or somatic states and feelings. So it's just kind of a numbness or an inability to identify how they're feeling. They can also have difficulties with affect tolerance. So being able to be with difficult emotions without having a big reaction to them. So what you'll see, if there's difficulties with affect tolerance, you'll see numbing. They'll be numb. They won't have any access to kind of the somatic resources for some interventions that we do. They just won't have awareness of their body. And that numbing is done so that they can tolerate the level of emotion that they're experiencing. So it serves a function, but it becomes problematic later on. They can also have extremely intense emotional states with very impulsive behavior. So this is drinking, suicidal behavior, self-harm, eating disorders, compulsive gambling. That's more your fight or flight energy, where it just really they become very impulsive because they need to get away from the emotional distress because they can't tolerate it. And chronic shame is another area that is an emotional behavioral impact of complex trauma. And my approach to complex trauma and the shame that goes along with it is to frame it as something, it's serving a function for some purpose. I look at it as a protective collapse that helps to minimize further damage or further threat or further danger. So it's this kind of hunkering down into yourself, pulling in so that things outside don't impact you, or you're not as noticeable as a target for somebody that is dangerous or a threat to you. The difficulty is this can create more vulnerability to victimization. So it does work, but it can create more difficulty for victimization. It's also a terrible emotional state to be in and to feel, because it's very, very heavy. So it does serve a function. I believe it's important to help our clients understand this, but we also need to move away from it. So how I work with that is I try to separate that response, that protective collapse, from the thoughts that they have about themselves, like I'm a bad person, nobody loves me, I'm not safe. So that response is an attempt to protect against further victimization. The negative self-beliefs or shame help strengthen this response so that the function would be to get more protection. But those thoughts aren't even likely true. So separating the response from the thoughts and kind of disconnecting that, those thoughts no longer kind of reinforce that protective collapse. So that's a very brief, again, that could be a whole training in and of itself. So this is why complex trauma is so difficult to treat, because this is just one small piece of the puzzle. And then when you have it in the context of intergenerational trauma, you've got even more layers. So this is where the complexity becomes difficult to manage, and it can feel like you're not making any progress in therapy. So the impact of the emotional and behavioral things that happen for people in these patterns in relationships. We're going to look at the parent-child relationship with partners, and the therapy relationship. So the parent-child dyad that has experienced complex and developmental trauma. So the parent may have complex trauma symptoms. The child is experiencing developmental trauma. You can end up seeing very controlling, disorganized attachment behaviors in the child. And there's two subcategories of these. You've got the controlling punitive, which is a child that's highly demanding, prescriptive, bossy. They are totally in control of the parent-child relationship, and they can be quite aggressive in doing it. The other one, the controlling caretaking, it can slip under the radar because the kids who have that type of disorganized attachment, they can look like they've got it all together. They're helping their parent, they're helping raise the siblings, they're functional, they can keep it together. But once you pull them either out of that situation or block their care for other people, they can become controlling, punitive, and they can just implode when those responsibilities are taken away from them, because that's how they're managing their attachment anxiety, their fear, and all those parts of fight, flight, freeze. So it's serving a function, but it's not healthy. And once you peel that away, you can have huge like decompensation in relationships in school and in mental health as well. So that's a tricky one that's really important to keep an eye on if you see parentified kids, because it's that subtype of disorganized attachment that's caretaking. So the impact on parenting, there's basically three ways. There's probably more, but the three primary ways are difficulty with co-regulation, negative mentalization of the child, and parenting strategies that backfire. So with difficulties in co-regulation, typically when a parent is impacted by complex trauma and they have those emotional and behavioral impacts, there's significant dysregulation in the caregiver. And when you look at the parent-child relationship, this creates really significant co-dysregulation with the child. So they can dysregulate each other very quickly. It can be traumatic for both the parent and the child. Sometimes kids in these situations can really traumatize the parents. And it's because of this co-dysregulation and all those attachment drives and all those parts or that are kind of in conflict. So it obviously interferes with secure attachment. They can't form a secure attachment when there's all this conflict and there's no co-regulation, but only co-dysregulation. The negative mentalization of the child is we want to look for beliefs in the parent that the child is willful or doing things on purpose or trying to drive me crazy or just not understanding that the child has impacts. They're ascribing it to the child's personality or that it's a choice and they're doing it on purpose, because this further divides that attachment and puts them in a lot of opposition. And then parenting strategies that backfire, they're typically either disconnected or very harsh and punitive. So the disconnected parents may have a lack of engagement. They may just let the kids run wild, no boundaries in the house, no rules, no structure. And they're just disconnected and they can tolerate it, but they're pretty shut down. The other side is that those harsh punitive strategies where you'll see them use behavioral interventions, but they'll be pretty severe and they'll be so hooked on those behavioral interventions that if the child acts out after they do some type of behavioral, like a timeout, they'll up the consequences or they'll up the behavioral intervention more and more and more, and it just continually backfires. Because those behavioral interventions trigger that whole system of those animal defenses and things that those trauma responses. So now we're going to look at how this impacts a relationship with a partner. So typically there's high rates of instability in these relationships. There's usually a pursuit, avoidance, or attack cycle where one person will pursue and will want attachment. That attached part is strong. And then once the person turns around and says, I'm here, let's work on this, it triggers that intense fear and panic, and you'll get a fight or flight response, which will be avoidance or attack. So there's this cycle, and it can lead to family violence. This is the root of a lot of relational violence, where when somebody tries to leave, that's when they get attacked, or when somebody tries to come close to somebody, there's conflict or disruption in the relationship. One of these Another thing that can happen is like caretaking of a partner. So, and the partner has significant difficulties that creates like a codependency. So you'll see this in addiction and violence, where they go to all lengths to take care of the person who's actually harming and hurting them or causing distress within their life or the family. In therapy, it's really important to understand how these difficulties can impact the therapy relationship, because if you're not aware of it, they will catch you off guard and it will be very difficult. So, the first way that it can impact therapy is that they may be phobic of all things therapy, even the therapist. So they're phobic of emotions, phobic of nice, calming spaces. They're phobic of a warm, friendly, supportive person. So they have a lot of anxiety because they haven't had positive, safe experiences in relationship around emotions and being supported. So they can have a significant fear and distrust of both the therapist and the process. So they may resist every kind of intervention you want to do, and they may put up barriers with making progress because they're so fearful of what therapy is all about. So this is why in the 5 domains of assessment of the impacts, we consider the impact of intergenerational trauma on the therapy relationship and process, because these are highly likely to appear in the therapy setting. Another impact on the therapy relationship is that the therapist can become a trigger for attachment trauma. So you'll see that push-pull between the attached parts where they need the therapist, they want the therapist's input, they may seek you out between sessions and difficult boundary issues, and then they may kind of attack when you respond or when you get closer or when you bring something up that they're not comfortable with. So we have to be aware that even though we know we're safe and we know we're there to help them, we may be a very big trigger for all of that attachment trauma. And warm and fuzzy isn't always better. So some of us have a concept of therapists as being very compassionate and very supportive and warm and caring. And sometimes that type of intervention or presentation will significantly trigger some clients that have a distrust for therapists. So with those clients, it's usually better to be matter of fact and not put on a lot of empathy and compassion. You still want to have that, and you still want to have that in the therapy relationship and on your thoughts and beliefs about the process and the client, but the way that you show that is very different. It can't be that warm fuzzy for some of the people, because it's such a trigger for them. The other impact on the therapy process can be dependency and high needs between sessions or high needs for more time. So because they haven't had previous attachment models and they have really strong attachment drives and possibly disorganized attachment strategies, the client might become really dependent on the therapist. And in most therapy relationships, there is a bit of dependence that we have to manage very well. We have ethics around that. And there may be some of that because we're emotionally supporting people. But it's that strong attachment drive and the lack of previous attachment models that can be a real problem for people with complex trauma in the therapy setting. So what you'll see is high number of crises or demands that they make. They may need excessive time, or they might want to have appointments more frequently than what is therapeutically recommended. They may want frequent contact outside of therapy. So these are all things that can become boundary and ethical issues, but we have to manage them in a way that doesn't trigger rejection, abandonment, and all those types of difficulties that can come when that attachment need is frustrated. So, this is the importance of strong and clear boundaries with compassion. So, we don't want to be militant about our boundaries, but we want to be strong and clear from the beginning of therapy and have your structure and your boundaries very clearly defined with clients who are impacted by complex trauma. And these are the boundaries that are specifically related to dependency that can interfere with therapy. So you want to clearly discuss the therapy process, like what happens in therapy, so that they have a better understanding that you do kind of taper off. Like you may come once a week for a while and then go down to every other week and then once a month and then termination. Um, and that can be, if they don't understand that, they may think they're going to come once a week for the rest of their lives, and it can be very hard for them when they realize that there's a therapy process and people don't stay in therapy for forever. So it's really important to have those things identified up front in your policies about no shows, about contact between sessions, about how you're going to handle emails and phone calls, because this can become very disruptive to other clients and your practice if you don't have those boundaries defined. So this will also help when you have everything clearly defined. It will also help decrease the tendency to personalize it, like a rejection or frustrating that attachment drive. So this is where, in the context of intergenerational trauma, the 5 domains of assessment are so important. So this assessment is usually done at the beginning of therapy and through your intake process and your referral process. So you can collect information from, if you're working with child welfare agencies or referral sources that would have this information, you would you'd ask questions about the parent-child relationship, how they view the child. You want to get a good handle on that. Or if you don't have access to a referral source like that, you can do this at intake too. The thing to keep in mind, this isn't an assessment that gives you a number that you can say this is the baseline. This is a continual assessment process throughout therapy, because these layers of complexity with intergenerational trauma and traumatic attachment, they unfold over time. So you want to be aware of things that are going on now and what may unfold over time. So one thing to consider, like one example would be a person who really wants their child to get therapy, and they're very supportive. They get them in, they're totally committed, but then they won't engage in any kind of parent consultations that you want to do, or they stop, they have somebody else bring them to therapy, or they start missing appointments. And that's the impacts on the therapy process, that intergenerational trauma and that unresolved complex trauma in the caregiver can be problematic within the therapy setting. So that continual assessment helps you kind of keep an eye on where things are at so that you can address them before they get big or before they end up hurting the therapy process, or slowing down the progress or early termination. So now we're going to look at psychological and emotional fragmentation. So this is from that interpersonal neurobiology approach. This is a lack of integration. It's difficulties with linkages, and there's too much differentiation. So it's like islands of experience and self-understanding. So the differentiation can be so significant that there's no awareness or memory of parts or experiences. They're kind of walled off or cut off. So this creates experiences and responses that are they're either disconnected or they're just shattered. So there's no cohesive experience or narrative of an experience. So if there's a car accident and it's highly traumatic or triggering, then they won't have a cohesive experience of that accident and what happened before, what happened after. in the way that they understand it may be very kind of fragmented as well. This can lead to further mental health and relational impacts because these fragments, people don't understand why they can understand this but can't understand this part of it, or why they can't remember what you had said or done to try to help them, or those kinds of things where that there's way too much differentiation, and it could even be kind of walled off with no memory of experience under different states. So typically, fragmentation presents as dissociation, and fragmentation is part of dissociation. So Fisher talks about fault lines when we're under distress. So it's like a crack or a weakness where there's a fault, and when there's extreme stress or duress, that fault kind of slips or it disconnects. So there are one of the ways that these fault lines can occur are between right and left hemispheres. So that's your bilateral integration. Developmental trauma significantly impacts this because the right brain is very dominant from 0 to 3, and the left brain isn't fully online and developed until into later teen or early adulthood. So that's there's a lot of development and a lot of connections that are being made in that window. So you can end up having huge difficulties with bilateral integration if there's a lot of traumatic experiences or there's developmental interruptions in the process. So what you can see when people are right brain dominant or in a state that is right brain dominant is they won't be able to put words to their experience. They can't describe it. They can't understand it. They can't verbalize it, but they're totally experiencing it. Or you can have a very emotional response without the ability to verbally process. So it's a very difficult emotional response to try to help them cope with or use coping skills or form different interpretations of it. That's your right brain dominant. When you have left brain dominance, they're very logical and literal. So it becomes about the law of the land and justice. This wasn't supposed to happen. This isn't right. They'll want to write letters or do things, or they'll have this high sense of justice. And that's that more left brain dominance, or they won't be able to connect to the emotions of it as well. So that's one way that it will show up. And if we look at the structural dissociation literature, there's 3 levels of dissociation that can happen with severe and complex trauma. So your primary dissociation usually happens like with single incident PTSD. It results in like that life as usual part can go on, can function out in the world, and then those heightened survival defenses. So they may interfere, but the person is aware of them. They can learn self-regulation. They can do things to influence them, those survival defenses. Secondary levels of structural dissociation is usually found with complex or developmental trauma. And this creates further distinctions, more disconnection of those heightened survival responses. So your fight, flight, freeze, submit, and attach will become very strong. They'll become very, very strong. And they're more difficult to integrate into the person's experience. But the person is aware of them. Tertiary levels of dissociation is continued dissociation or disconnection between those parts, between those defenses and the life as usual. So what can happen is you'll see life as usual has very clearly defined ways of interacting, boundaries, roles at work with their partner or as a caregiver. So they'll be those roles will be highly defined and may cause a little bit of conflict. Like, how can you be so understanding with your colleagues at work, and then you come home and you're so angry and we can't even talk or work with you. So it's those types of splits. And those survival defenses have very little linkage when you're in tertiary levels of dissociation. They can become walled off where there's amnesia between these parts. So when a person went into a rage with that fight part, that attached part has no memory of it. So they're it's like that blackout. So they're really having difficulties with these, understanding the flow between these parts and how they're linked and also how they're differentiated. And this can result in kind of compartmentalization. And compartmentalization is when trauma parts are very well defined and they're more distinct. So instead of anger, you'll have an intense rage. And instead of a withdraw or kind of tucking into a person's self, you'll have extreme shutdown and just emotionally, cognitively, relationally, there's just a huge shutdown. So the trauma parts are more well defined and more distinctive. So these responses become more kind of, I guess you'd say, exaggerated or more significant. The person may have a lack of awareness between these or memory for those defensive actions of those parts that are trauma related. So they're not aware of an argument, or they end up being at a store and they didn't even remember why they went there or why they drove there. So this is where you'll start to see memory gaps and loss of time. So dissociation is really important in intergenerational trauma, and we're going to look at why it's so important. First of all, it's necessary and it's highly adaptive under very difficult or very threatening circumstances. So it's important to manage that conflict, and this is the function of it, is it manages the conflict between pursuit and fight and flight. And that's why you see it more you see dissociation more when there's disorganized attachment, because it's the conflict between those two that it's adaptive to minimize that conflict when you're in highly stressful or very traumatic situations or environments. So disorganized attachment becomes a key indicator of intergenerational trauma. And wherever you see disorganized attachment, assessment of intergenerational trauma should be done, especially when you're working with the children and teens. If you get a referral for a child and you're thinking you're going to do play-based behavior or play-based interventions and work primarily with the child, if you see disorganized attachment, you've got to bring in caregivers and may need to look at how the whole family system, from the parents down to the children, can be supported to address those impacts. And the therapies for these will be discussed in a later lesson. Now, the last area that becomes important to look at is those trauma bonds, because they're very common in complex trauma and intergenerational trauma because of the family nature. Like it's hard and sometimes impossible for people to cut off their families when there's significant danger. So these trauma bonds develop as kind of a survival mechanism, but they can be very problematic for other relationships, for the person's self-worth, self-identity, and for the therapy process. So these are really complex dynamics between like a victim and an abuser, and it's often seen in traumatic bonding. So one of the characteristics is this intermittent reinforcement, and that means that there's no number of times or length of time that you'll get reinforcement from the person. So this is very behavioral. It takes me back to my behavioral roots, where this is why gambling is so effective, is you never know which push of that button or pull of that arm you're going to get the reinforcement. And in relationships that have traumatic bonds, the abuser alternates between abusive behavior and positive reinforcement. So the rewards and punishments are really unpredictable in these relationships. And that can create a powerful emotional bond that it's hard for the victim to break. There's usually also power imbalances where there's a significant imbalance in power where the abuser may have control of finances or resources, and it puts the victim where they have less control or less influence in the environment or the relationship. There's fear and dependency. So a lot of times, because of the trauma that they've experienced, there's a lot of fear that goes along with that. And they become dependent on the person who is abusive. So they don't see how they can live without the abuser because they're so fearful, and they may be dependent for emotional, financial, or physical support. And not that the emotional support is very healthy, because again, it goes back to that intermittent reinforcement, power imbalances, and all of that. There's typically, when there's trauma bonds, there's typically a lot of isolation. So it may be a family that is very kind of closed, in a closed system, and they don't allow a lot of people into their family. So there's a lot of isolation. It may be from friends, family, support networks, anything that increases the reliance of the victims on the abuser. So they reduce outside influences that could challenge that trauma bond. Also, when you have trauma bonds, there's typically an erosion of a person's identity. So they kind of lose who they are, and their self-concept begins to erode because of the influence of the abuser, which is all usually undermining the victim's sense of self-worth or identity. And it's linked to that lack of self-identity that we talked about in recognizing difficulties with complex trauma. Trauma bonds also share traumatic memories. So these might kind of, when you have when you go through a trauma with another person, a lot of times that group are the only ones that understand completely that experience because they were there. So there can be times where trauma and situations involving danger, they kind of fortify that emotional connection, and they really make it stronger. And it makes the victim feel a unique bond with the abuser that they can't replicate with other people. So that can also be a difficult thing to address, because there is that bond, and then they're isolated and they don't have a good sense of self. So those traumatic memories and experiences can really forge like a very unhealthy connection. A lot of times when there's trauma bonds, the victim will justify the abuser's behavior, and they'll make excuses for it. They'll try to make it better. They'll have a lot of sympathy, or they'll try to defend them. And it's often beyond what's even logical. So people from the outside will think, how can you defend that? Or how can you support that person when they've done this, that, and the other thing? But this is how they justify staying in that relationship. And Stockholm syndrome. So this is where it's an extreme form of bonding. It's usually in like being taken captive or kidnapping, that involves, in order to survive, the victim develops positive feelings towards the abuser. They start to understand or identify with them. They start to genuinely try to help them, and they have sympathy for them, and they want to they'll stick with them and defend them, which just doesn't make sense to other people. This is a survival response. It's based in what Dr. Porges talks about as please and appease. They're placating the person, but then over time, if it's a long period of time or the intensity is too high, they slip into actually believing and supporting that person. And sometimes people who are abusive aren't all bad. They sometimes do have good qualities or even charming qualities where that intermittent reinforcement can really hook people in. And then you'll find that Stockholm syndrome. People who are in trauma bonds typically have a lot of cognitive dissonance. They can experience um, like difficulties reconciling the disparity between the love or loyalty they feel and the reality of the abuser's behavior. So they can have a lot of like splits. So it's really important to, when you have those self beliefs and they're negative, to look at the cognitive dissonance in the relationship with an abusive person if there's a trauma bond. And there's also that cycle of abuse. So the relationship follows a cyclical pattern where there's periods of abuse followed by apologies, affections, gifts, change that temporarily soothe or smooth over what happened, but it reinforces the bond and the cycle will start over again. So these trauma bonds, they are common in intergenerational trauma at the more extreme end because it's happening within a family. And a lot of times families are either shut down or there's a lot of volatility, that you can find these trauma bonds within families impacted by intergenerational trauma. And it totally complicates the recovery process and therapy. So we need to have strategies to adjust it. And where you'll see the impacts of, so we're going to look at the impact. And we just went through the characteristics. We'll look at the impact and how it complicates and what strategies to use. So the first impact on their therapy would be resistance to change. And I don't like calling clients resistant because it's an adaptive response that's no longer useful. But this is where they'll resist change. They won't want to make decisions for themselves. They'll put up barriers in therapy. So they may resist recognizing the abusive nature of the relationship, or they'll have conflicted feelings about leaving. So this is where motivational interviewing can help explore that ambivalence and kind of guide the victim towards recognizing their own needs and the reality of the situation. Next complication is fear of retaliation. And this is a very real fear. So if a person decides to make change or leave a relationship, that's the highest risk time for something really bad to happen. So this is a very real fear that the abuser will retaliate if they try to leave or change anything in the situation. So this is where safety plans become really important to address all those things that may come into play with needing emergency contacts, identification, all of those things. And this is a very real fear. This isn't that their fear response is a little too high. These can be lethal situations. So that's one that we have to really work with diligently and have those safety plans in place. Another complication can be low self-esteem. So being in a relationship where there's continued abuse, the person starts to believe that I'm a bad person or nobody will love me, I'm damaged goods, and that's why this is happening. So it's hard for them to even consider that they may be worth more, or they deserve better treatment. So one of the strategies for that is to look at CBT to build self-esteem and recognizing those negative self-beliefs. I also believe DBT can be good for this, for those interpersonal relationship skills. And also any of your EMDR or brain spotting can help with those negative self-beliefs as well. The dependency on the abuser can be a difficulty as well. So they may have emotional, financial, physical dependence that make a victim feel like they're unable to cope without that person. So any child, teen, or person with a physical disability that depends on an abusive person to help them get around or to take care of things that they need taken care of, that's a true dependency that is going to be very complicated to support that person. So what we want to do when we find this situation is we have to strengthen those support networks, and we have to get other people and agencies or things that help support that person to provide more resources for independence and empower them with decision-making skills. They may also have a tendency to minimize the abuse. So victims may minimize how severe it was so that they can cope with it. So if we don't want to go right up against those beliefs and how they can minimize it, but we do want to reflectively listen, let them know we're hearing, validate their experience, and gradually help them acknowledge and articulate the abusive aspects of the relationship. So one thing that I think is important with this is using the middle path of DBT, where you look at those dialecticals, seemingly opposite things, but they have an overlap or some kind of synthesis between them, helping them see that synthesis much better, so that they can kind of see the severity of the abuse. Emotional dysregulation is another thing that can impact therapy. So trauma can lead to difficulties managing coping skills and emotions, and it can really lead to some instability in therapy. So this is really important to have strategies to support them with emotion regulation, to keep therapy more stable, to keep them engaged and committed to coming. So we can use things like mindfulness, grounding exercises, the distress tolerance skills from DBT. Those are all helpful for the high degree of emotional dysregulation. An additional difficulty is the cognitive dissonance that victims sometimes have to align, like, their emotional attachment to the reality of the abuse. It can cause a lot of confusion and stress. It's hard for them to they have a lot of cognitive dissonance between those two. So you'd use gentle confrontation and dissonance reducing techniques to help align them to see their thoughts and feelings with the factual aspects. So this, again, maybe that middle path with DBT, that would be helpful. Another difficulty is they may be very isolated from support systems. So this can prevent victims from seeking help or from gaining perspectives or other people's interpretations or experiences that challenge that trauma bond, because they may think this is a normal relationship, this is how all families work, or this is just, there's nothing different for me than it is for anybody else. But when they have a support system or kind of connect with other people and realize other people may not be experiencing the same thing, that can help them kind of reconnect with other people, reconnect with healthy family and friends, and involve them in the therapy process, those family and friends, when it's appropriate and with the permission of the client. So that's sometimes where, in the last phase of the intergenerational trauma program, there's the building connection and family resilience. This is where you can bring other family members in and build those resources and supports. Another difficulty is that trauma bonding can be reinforced by the cycle of abuse. So there's the cyclical nature of abuse and reconciliation. So that's that cycle and that pattern, and that reinforces that trauma bond. So we want to educate them about that cycle of abuse and helping them recognize those patterns and understanding their role in it, and just understanding that so they can kind of be more aware of it and understand the context and the impact on their lives. So shame and guilt is also very difficult for people impacted with traumatic bonds. So victims, they're often shamed or feel very guilty about their situation, or they have been told they're a terrible person, or they always do things wrong, that they believe that, and they have a lot of shame and guilt around that. This can silence them or make them very reluctant to even talk about what they're going through. So it's really important to have skills and strategies to deal with that shame and guilt. So we want to use a non-judgmental and compassionate approach, creating safe therapeutic environment, and slowly encouraging open communication and reducing those feelings of shame. That's why when I work with shame, I frame it as it's an adaptive response. It's a behavior that then has thoughts, and we need to kind of pull those, we need to differentiate between those because the thoughts may not actually be true, but when you believe them, it's going to reinforce the shame. So a lot of these complications are already vulnerabilities of a client who's experienced developmental trauma in childhood and has that unresolved complex trauma in adulthood. So this is where, excuse me, this is where they're already vulnerable to to trauma bonds based on having had developmental trauma in their own childhood. So we really need to consider the context, the overall context of the family, and focus on safety first if there's any of these trauma bonds that are present, um, particularly when there's higher risks related to those trauma bonds, risks of violence, those types of issues that can be very difficult. So there you have it. We have talked about how to recognize complex trauma in the context of intergenerational trauma. We looked at understanding self-identity and sense of self, emotional behavioral patterns in relationships, psychological and emotional fragmentation, and trauma bonds. So next lesson will be on creating safety in therapy for clients with unresolved complex trauma. So I will look forward to seeing you there.